Hey everyone. In this episode of Think on This with MHA Lakeshore, I spoke with Julie Preder, who is the executive director of MHA Lakeshore and also my boss. So, Julie defines her 25-year career as a gift to serve others, and she's an advocate for highlighting social determinants of health relating to barriers to access of care. She's also dedicated to implementing stigma reduction, social inclusion strategies, and strives every day in her work to normalize the conversation surrounding our mental wellness. Her passion for serving vulnerable populations and the health and wellness of communities at large really led her to get her degree in community health education from Hunter College in New York City. She holds certifications in suicide prevention as a Master ASIST Trainer, a QPR trainer, and also holds certifications in bereavement counseling, field traumatology, and health education. In 2018, she received the Award of Excellence in Health Promotion and Disease Prevention for her work on the Cultivate Mental Wellness model from the Wisconsin Public Health Association. She was recognized at the national level and presented at the National American Public Health Association Conference in San Diego. I chose to speak with Julie because I thought that her insights into the nonprofit world of mental health is something that everybody should be aware of. She has had a really interesting career that allows her to see public health from a very unique perspective, and she is just such a cool person. We talked about so many different topics, including what it means to be an executive director, nonprofit operations, trauma, and mental health's intersection with violence. It was really just an awesome conversation, and I hope you all enjoyed as much as I did. Welcome back to the Think on This podcast with Mental Health America Lakeshore. I'm your host, Keegan Reines. Mental Health America Lakeshore is a nonprofit resource and referral agency based in eastern Wisconsin. We are dedicated to helping individuals access mental health services and providing community education around mental health topics. The Think on This podcast is a broad look at the world of mental health in the hopes that through the stories of those who engage in mental health each day, we can provide much-needed clarity to this subject. Some of these conversations may be difficult for listeners due to the nature of these topics. If you are ever feeling overwhelmed, I invite you to pause the conversation and take care of yourself. There is no need to power through this podcast, as you can always come back to it later. Please be aware that nothing said here consists of medical advice, and if you are struggling with a mental illness, reach out to the appropriate professional. Lastly, I want to take the time to thank you for listening to this podcast. Our vision is that through these conversations, we can create mentally healthy communities where all individuals thrive. By listening, you are a part of that mission. Welcome, Julie. Thank you for being here. It's amazing to have you on this, and I think this conversation is going to kind of peel back a lot of the skin of what the underside of nonprofit work in mental health kind of looks like.
I hope so.
I think people really need to understand that kind of environment. So if you could just give me like a brief just overview of how you got to this position and why you want to work within mental health.
Sure. Wow, that's sort of a loaded question. It's been a long journey here. And, with each position, I always say, all of these roads, as they have for every single person, has led me to this. This was my aha moment when this position became available. It was, okay, everything I've done has led to this. But I've always known that I've been wanting to go into the field of helping others. And so I've been doing this work for, over 25 years, and I have worked boots on the ground doing outreach with communities from California to Florida to New York, now to Wisconsin. And at the heart of all of that has been that one-on-one connection with individuals. And, you know, everything that I've done has been revolved around mental health, because when you look at the core of nonprofit work, it really is lifting individuals, whether they're looking for food or housing or whatever it is our mental health that is at the core of what individuals need to have in a very well space in order to have all of your other needs met. And, you know, when I first got into the field of nonprofit work, it was in New York City. I worked for this organization called the Floating Hospital. And it was a hospital that was on a boat in the harbor. And individuals from various different homeless shelters, domestic violence shelters, they were in shelters at the time, and they came for parenting skills, dental care, medical care. And that was sort of my first boots on the ground, working with individuals. And I was working with moms and babies at the time. And I just knew that this was something that it was my calling, and I wanted to continue this work. And I did a lot of work throughout my 25 years with women and children. I came into specific work with mental health when I was working for FEMA, and I was doing work as a public relations coordinator and working with individuals that have gone through disasters, and how do we lift ourselves with such tragedy. You know, we think of tragedy in all different ways, but we don't talk enough about what natural disaster looks like for individuals.
Could you please give just like a little synopsis of what FEMA is for our listeners, for those who haven't heard of it?
So FEMA is really that response in the United States when we have a federal disaster. It's our federal emergency management program. You know, a governor declares at a time when a natural disaster occurs, you know, we're declaring a natural disaster, and allows funds to be lifted through the federal government to assist those states. And I was living in Florida at the time, and just, you know, seeing what was happening. And, you know, we were always having hurricanes, but this was right around when Katrina happened, and Wilma occurred right after that. And, you know, so working with those families and those individuals who were trying to pick their lives back up again was my first introduction into working, you know, one-on-one with poor mental health. What was it looking like for those individuals? And that led me on this path of getting my credentials around traumatology. And I went on to work for the Army National Guard in the state of New York, overseeing their suicide prevention work for the entire state and investigating what those suicides look like for military members, active members. And, you know, very long story short, I ended up back in Wisconsin. I was raised in the Midwest, and I was gone for 30 years. I never thought I would end up back here in Wisconsin, but here I am. And my degree is in community health education, so public health. I ended up coming back and working for the health department, and at the time, those two health departments of Ozaukee and Washington County were merging, and I was overseeing their mental health initiatives. And I worked with them for several years, and then this opportunity came up where we live here in Sheboygan through Mental Health America. And, you know, as I said at the beginning of this, you know, sometimes it's this aha moment when a job comes up, as you know, because I think you had the same when you came here. You know, and it's, I've directed, I've led, I've done all of these things, I've managed, but this was a new position for me to be that expert in all of those things, from HR to finances to, you know, I think we don't understand how complicated nonprofit work can be. And the majority of nonprofits out there are small. So you're, as an executive director, you're doing it all. You know, we don't have an HR person here. We don't have an accountant. You know, we don't have maintenance. You know, we're doing it all. And as you know, just taking down the fire alarms last week, you know, we're doing it.
Yep.
We're having to do it all. So it's been an eye-opener for me to come into this role. And then you want to be the best leader that you can be. You know, you in this field, you want to continue to inspire your team to do the best that they can. But you also, as a leader, get that inspiration from your team too. So it's you know, you're giving and you're taking, and you're giving and you're taking constantly, daily, to make sure that in the end your community needs are being met.
That was a very good response. I want to come back to a lot of that, especially the traumatology and some of your work down in Florida. But as an introduction, could you just give me a little bit of information about Mental Health America Lakeshore and what we do within the county and the counties near us?
Sure. So we are currently switching over from Mental Health America Sheboygan to Mental Health America Lakeshore. We're very excited about this. We went through many different names, and I'm actually happy that we ended up on this one. We will be 70 years next year, 2023, in our community.
And we just found that out as well.
Yes, we did. We thought we started in 63, which we were going to say 60, but our charter actually states it's what do we got up here? It looks like
1953.
Yes, 1953.
It's the plaque that's hanging up in our meeting room, and
it's been staring at us the entire time. So back 70 years ago, the majority of the mental health associations, that's what we were known as, we were the Mental Health Association. And the state of Wisconsin, I don't know how many we had here. We had several charters throughout the state. We only have two affiliates, we're known as now, left in the state of Wisconsin: MHA Wisconsin, MHA Lakeshore. And we are one of 242 affiliates across the nation. And our flagship, our mothership, Mental Health America, oversees a lot of our campaigns, initiatives, but what they're really doing is pushing forth that policy for the nation, along with, I know a lot of people that might be listening here may say to themselves, oh, I've never heard of Mental Health America. Another organization that does advocacy work would be NAMI, the National Alliance for Mental Illness, very similar to Mental Health America. And we're really leading that voice for the nation on parity for all. We want to make sure that we are pushing and holding all systems accountable, that mental health has the same rights as physical health. And I always give that example, you know, if your employee breaks their arm at work, do you just say, well, too bad? No, if somebody's suffering or if they've had a loss or whatever that looks like, we all deserve to have the same conversation around our mental health. So I divert. So Mental Health America Lakeshore, at the core of what we do here is really that navigation, that point of entry into mental health services within not only our county, but our surrounding counties, because we have individuals that connect with us and contact us from all over the state, and they're looking for that support. They're looking for those answers. So our resource program, our individual assistance program, has been at the core of our work for 70 years, is making that connection for those community members. And over the years, we've grown to have education and training as part of our programming. Our Mindful Classroom initiative, I think, was probably one of the biggest programs, and the former executive director, Kate Baer, hello, Kate, if you're listening, really brought this cutting edge idea to Sheboygan County to say, you know what, we need to support our school systems around social emotional learning. I want to bring in staff to support this within the school district. So our Mindful Classroom initiative started almost 6 years ago, and that is going strong. And the work that you're going to be doing, Keegan, in the schools. And by the way, if you're listening, all the kids love Keegan. He's already received little artwork and poems, which is so great. I think it will speak to having a male in this role, because I do think when you look at nonprofit work, it's predominantly heavy with women working in this field. And I would say, you know, with teachers too, we have a lot of educators that, you know, are female. To have a male in this role for these children to look up to hear another voice that's out there, it's already speaking to the response that you're getting out there from these kids.
I mean, that's a difficult area to navigate, as the mental health field, it's already pretty deeply stigmatized. And even within that, we have stigmas, especially with men with mental health, elderly mental health. And so I think that's something that within the nonprofit, being primarily female, that is something that's been kind of a roadblock.
Absolutely. And I would say across many of these different categories of the work that nonprofit does, I don't think that we have enough men that go into this field. I mean, it's definitely changed. The same with nursing. You know, it's that helping role. There is stigma around it. But we've come such a long way. I believe this will look very different within the next 20 years. And we've come so far, but it's just leaps and bounds every decade that we're seeing in these systems. So, and then to finish on that, advocacy is also one of our main pillars too. We can't do this work unless, we're advocating on all levels. And that includes our donors, our supporters, our community members that access our services. They're all advocating on some level. They may not know it, but they are. And every single time somebody reaches out, they're advocating not only for themselves, but for others.
So you touched on a lot of things that I want to come back to, but I just want to get, what does your day look like?
Yes.
What do you do on a day-to-day basis as Executive Director Julie Preder?
Right. Well, how do I answer this? I feel like I have a plan every day I come in, but it just, something happens. But it's connecting with those individuals that have come in the day before. I always put community members and our donors first. What is the response that we need to give to them immediately that morning to make sure their needs are being met? And from there, I said this to you before we got started this morning. We're sort of like little tornadoes in nonprofits because there's something coming at you at every angle all the time. And for our organization, and I don't know how you feel about this, but I feel there's a request coming in for a need from a system, not necessarily an individual, but a system out there every single day. We're having, something going on in the workplace, let's say, or we're having an event, or we're having this, or we're having that. And we recently brought on a director of strategy and partners, which Dana has been wonderful because she's really put us through a system. Because if we said yes to every single thing, I don't know how we would get any other work done.
Absolutely. Mental illness never stops.
Right.
And so we saw that even like this weekend, having people reach out, and unfortunately, mental illness and suicide doesn't doesn't stop over the weekend, and those needs that we feel are important to meet don't stop for holidays or for weekends. So that kind of, the little tornadoes, I really like that analogy, because a lot of times that's what it feels like. And Dana has come in and put that corporate measure into how we look at what are we going to do this next week. But there's still people that need assistance from us and that are coming every single day.
Yes. And it's interesting because you said corporate, and, we joke with Dana a lot. She's come from a huge corporation here, but she served on our board for 5 years. And there is a fine line with nonprofit. It's, and people always say, well, you're a bleeding heart. You've gone into this work because of this or that. There's no, there's a big talk on nonprofit and financial value too.
Yes.
The salaries are lower. We shouldn't have to pay for your services, or whatever that conversation looks like. And there's a great gentleman who I actually worked for, Dan Pilata, who started the 3-day breast cancer walk, and he did the bike rides across, the world and Africa and all of these things. And it started out for HIV, and then it went into breast cancer, and and one of his missions and his conversation around nonprofit is nonprofits can make money. Nonprofits, have just as much value as another corporation out there. And it's okay. It's okay to make money. It's okay to turn that profit that you make back into the community. And
that was one of the, just thinking on it, when I first started working here, and the first time I heard the phrase that it's okay for a nonprofit to make money, that was such a shift in mindset for myself, as this is the first nonprofit that I've really engaged with at like an employee level, where coming from the outside, you're thinking nonprofits are just taking money and doing as much as they can with it and asking for nothing in return. And when I thought about it, it just made so much more sense that nonprofits should be making money.
Right.
Because if they can make money and they can take donor money and then implement it in a way to make more money by giving services to the community and asking for those who can to pay for it, then that can only grow the nonprofit, so we can reach even wider group of people. If the people that can pay for it do, then we can reach even more people that can't pay for it. And so that was one of the huge shifts in mindsets that I had kind of coming here. And we're kind of on this next topic that I wanted to talk about is, what is major differences in working in nonprofit? What is very unique about nonprofits? What makes it more challenging working in nonprofits?
Yes.
I feel like there's a whole conversation right there.
Yes. So I'll answer this question first from our geographic location. We have so many nonprofits in our area. And I'm not saying that's a bad thing at all, because we have so many needs. I was recently having a conversation with somebody in the governmental sector here. And, when COVID hit, let's use this as an example. It is our nonprofits that are the backbone to meeting the needs of what is going on within our community. Now, imagine you don't have any nonprofits. What's happening out there? Housing, poor mental health, food insecurity, schooling. You think about the Boys and Girls Club. They set up right next to us in this church for kids that didn't have Wi-Fi. Is the government in any kind of municipality prepared to answer? And I've really thought about this after COVID hit. You look at nationwide, what government was able to come in and actually meet all of those needs that I just discussed? Probably none. At the level that a nonprofit in any municipality across this country was able to step up immediately and do that. Our nonprofits, the majority of them, when COVID Safer at Home hit, the United Way came in and said, you know what, we're going to provide an umbrella here. And it doesn't matter whether you're getting funding through the United Way or not. We're asking you to the table to have a system of nonprofits in place to answer the call of those needs within our community. And it worked well. And we had toolkits out. We had resource guides. It was amazing. And I think it speaks to the level of collaboration within this area. And what is also unique, we have many corporations that are based out of this area. And I know it allows our nonprofits to thrive at the level that they do because we have amazing employees that give through their corporations, either to the United Way campaign or they do campaigns for us. Like, I'm going to give a shout out right now to Johnsonville. They had a penny war at one of their satellite offices here, and they just made this huge donation to us from a penny war. It's little things like that where you have employees doing amazing things within their companies, and then you have these huge corporate headquarters here that give to the nonprofits. I can say from everywhere that I've lived, that is very unique. Of what's happening here. I feel very blessed to be running an organization here as my first executive director position, to have had this experience. That has been amazing for me. So you talk about it almost like nonprofits, like a group of nonprofits is almost the foundation for meeting a lot of the needs within our societies, because a lot of what nonprofits do, the government just doesn't. And I was wondering if you could elaborate on a little bit more about that. So, we don't receive federal funding. I know a lot of the organizations that we collaborate with do receive federal funding, and it's very competitive. It's competitive across the board. Doesn't matter what kind of funding you're going to go for. But if we did not have the value in nonprofits, and I'm just not going to say that here for our area, nationally, if we did not have the value in nonprofits, we would have many individuals across this country falling through the cracks at a higher level than they are already. And I will speak to all of my counterparts across the nation. This is hard work, trying to get funding to keep the lights on, to keep your brick and mortar, to keep staff on. You look at budgets of nonprofits, they're not spending it on, a foo-foo stuff, a nice desk. As you know, I went on, Craigslist and bought, all of our furniture that's here. Everything's, we are putting our money towards people.
We're renting a parsonage.
Yes. We are.
A falling apart parsonage, but
literally
we make it work.
Yes. For those of you that are listening, imagine 100-year-old home that's very unique looking, that is adjacent to a church that rents this to us. And
possibly haunted.
Yes, but good. We call it the MHA vortex. So whatever we want to have happen in a positive way happens to us. So we're not sure who's living up in the loft here at the MHA house, but good things are happening.
So that's a common misunderstanding about nonprofits, is what they do with their money.
Right.
What are some other misunderstandings that you have people come to you with, or that you engage with in the community?
that we should exclude certain communities. So it's, I think when you look at nonprofits, you're applying for this funding. Who is your community? Who are you doing these services for? Well, in the end, it's everybody. Mm-hmm. You're serving everybody. And I think sometimes when, I know this because I'm part of many different nonprofit groups, you have supporters or donors that may not agree with something. And I'll use the LGBTQ community. You know, I've had individuals say, well, if you're going to give or if you're going to do programming around that, I don't want to support you. And I think you could take that with any nonprofit work. Well, if you're going to do this, because I'm giving you money, I don't want you to do this. Well, that's not how it works. And if you don't want to give money to us because we're serving A, B, and C community, then that's your choice. There's plenty of nonprofits out there. I think a lot of nonprofits struggle with that because donors want to give for certain things sometimes. And that's a hard no sometimes because you, as a nonprofit, you need the money, you're also going to stand with your mission and vision and morals and values as a nonprofit to say, no, thank you. Yeah. You know, you can find another place to go put your money. So I think, especially with mental health, we're very unique. There's so much stigma around it. Why is this person homeless? You know, why are you doing this? Why are you doing that? Well, in the end, you know, we have communities and populations of community members that need extra attention because they are at high risk of mental illness, suicide, poor mental health, whatever it looks like. So I think it's a discussion that we don't talk enough about in nonprofits is what does that look like when strings are attached to your mission?
To donations. Or even your board. I mean, I have worked with so many boards. I have to say this is the best board I've ever worked with. And we have handpicked our board also. We want individuals, you know, I always say I have 13 bosses, you know, I have to make sure that those individuals understand their own biases also. We all have them, but are you talking about what that looks like? That's an interesting aspect to nonprofit work in its own right, that your board is essentially made up of people that don't work within the field. I mean, one of our board members, actually a couple of them are accountants.
Yes.
I think we have maybe one behavioral health provider on our board.
Yeah, we might. Yes. I think we might be down to one now. Yes.
So we're entrusting kind of our mission to people that don't work in the mental health field in most capacities. So, I mean, we're blessed with the fact that we have a board that really gets it.
Yes.
And can really understand our mission and our values. But that could be a major hindrance to a lot of different nonprofits.
It is. It for sure is. And I think as an acting board or a functional board, if you recognize that, you will keep bringing in like-minded individuals. You know, and a lot of bylaws within a nonprofit may state you can only have, and I know our bylaws do, you know, you can only have X percentage of mental health people on your board. I mean, we know mental health affects every single person. But to be an expert within behavioral health is a different story. But I have to say I'm pretty sure every single person on our board has lived experience of some kind. They've lost someone to suicide. They are in recovery from mental illness. They're an attempt survivor, you know, whatever that looks like, they've walked the path. And that is one question every time we vet a board member, you know, why are you here and what is your lived experience around mental mental illness, mental health with either yourself or one of your loved ones. So it's important. It's one of our questions that we do ask.
I wanted to make a quick correction in this next section, as I said that mental illness is something that is not common, and I intended to say that it was not uncommon. But it's also not that common. One of the statistics that we use very often is that half of people will suffer from a mental illness at some point in their life.
That's correct.
So it's more about what is their understanding after having that mental illness or being connected to somebody with that mental illness.
Right. And what is the drive to change? You know, your board as a nonprofit drives where your mission and value is going. Everyone else is hired, you know, but that board is really that backbone to say this is where we're going. Of course, the executive director or the CEO and the team is making those recommendations and suggestions, but in the end, they're the ones who are voting on it. We just went through, well, because COVID came, you know, I think it took close to 2 years to get our strategic plan officially ironed out and focus groups and all of those other things. But, you know, it was something that was driven by our board. And you want to make sure those individuals, like you said, have that understanding of what is at stake for the community.
So we've talked a lot about the different aspects of your work in nonprofit, and specifically as an executive director, I feel like a lot of your work isn't specifically geared towards mental health. Like there's a lot of just trying to run the nonprofit so we have the capacity to even work within mental health.
That's right.
So I feel like you jump at any opportunity to get out there and speak about it and actually be able to engage with that aspect of our nonprofit. So with all that, what do you think needs the biggest change in the world of kind of nonprofits and specifically in mental health nonprofits?
Ooh. I think support and collaboration at a higher level. And I guess where I'm going with this, you know, I look at our team. I mean, we have so many ideas. I mean, there's so many ideas just passing back and forth every single day. And, you know, what ends up sticking? I mean, like this is one. We're sitting here and doing a podcast right now because you threw this out and it was a great idea. But when it comes to, and I'm going to actually answer this based on my affiliates across the country, my counterparts that are doing this work, collaborating at a level of, I don't want to reinvent the wheel. What is working out there? What model works? What's evidence-based? What platforms can we have these conversations? What's out there for us to be able to collaborate on different systems, and that can go even further into all the other work that's being done here. I think we're doing a great job in collaborating with other nonprofits and those that are doing the work on mental health. But because we are point of entry into services, we're understanding that. But I don't really know what the nitty gritty is regarding maybe hospital systems or clinics, or what are they seeing in there? We know that rates of self-harm have gone through the roof since COVID, especially with youth. But I'm not getting that feedback from maybe hospital systems. You know, this is the trend. This is what we're seeing. I think larger systems and nonprofits need to work at a higher level. And that has to be outside of our community health improvement plans, our community health assessments that we're doing. So I think that needs to change.
We've seen that lack of communication, not within nonprofits and other nonprofits or nonprofits within our community with the hospitals, but as well as hospitals in the community not communicating with other hospitals, especially within mental health units or behavioral health units, not communicating when they're full to other hospitals within the area, making sure that if they don't have any beds available, making sure that those individuals find another bed in a different hospital.
Right. And that is, this dream system that we all want out there, which is this continuum of care. Mm-hmm. If I can't do it, I'm going to make sure I'm still holding your hand, and you're going to get into another system, to enter a system. And it's unfortunate that, and I will speak only on mental health right now, sometimes it takes a crisis for an individual to enter a system in order for them to get help. Mm-hmm. For example, they have attempted to take their life, and thankfully they were found, or they sought mm-hmm. help. And now they're in a system. Now they're in the hospital. Now they're doing inpatient services. But what about that individual that's at home who did self-harm but didn't disclose it to anybody? Mm-hmm. And now they're suffering, and they can't get into their appointment because the next appointment is 6 months from now.
Mm-hmm. I mean, that's another stigma that's perpetuated within even our providers, that mental health has to be at a certain severity for an individual to actually receive that help. And that's something that, I mean, we're in a community that's at, like, some providers have a year-long wait time, and individuals are just not receiving the care when they need it.
Right. And as an organization, we are trying to plug the holes that mm-hmm. are all over the place and put supports around that, whether it be education, support groups, calling therapists, hey, this person needs to get in right away, or helping them navigate outside of the traditional, let's sit down and have some therapy. The silver lining has been virtual therapy mm-hmm. out of COVID, for insurance companies across the nation to lift restrictions around that, to allow payment to occur for virtual. I mean, psychiatry assessments were being done long before that virtually, because we have very few psychiatrists out there. And, I knocking on wood right now. If you want to go into psychiatry, go into psychiatry.
We have one psychiatrist within our county now?
I don't even know now where we're at with the number, but it is a crisis. That is a train that is coming at us very quickly across this nation. We need to be prepared for this mm-hmm. crisis around mental and behavioral health services. I know this is one of our questions later on. What do I want to see happen on a federal level? If you want to go to be a doctor, a psychiatrist, anything around the field of helping people, we as a nation should be helping pick up that tab for student loans, because we're not going to have the individuals that we need in these fields.
And that's a whole nother conversation we could have about entry into med school and what that looks like, and some of the discriminatory practices that med schools have. But one rope I wanted to kind of tug on was talking about individuals falling through the cracks. And one thing that you said earlier is that there's 242 Mental Health America's affiliates within the nation, and there's only 2 in Wisconsin.
Right.
And if you think about it, 50 states, there should be at least 4 to 5 within each state. But operating within a state that only has 2, one of which is a whole encompassing state affiliate, and then we're the single county affiliate, and we're branching out to more counties in the surrounding area. There's a lot of counties that are going to go without the specific care of a county affiliate.
Right. Yes, it's, I know that MHA Wisconsin, has a database for all of the counties throughout the state. They are the parent affiliate for the state. We want to support them as much as possible with those resources and information. But, a lot of the work around mental health comes within that community health improvement plan, which, if you're listening and thinking, what is a community health improvement plan? So it is a requirement by health departments and hospital systems to put together what's called a community health assessment. And then from there, a plan is put together, and we refer to it as the CHIP across the country. And mental health is pretty much a top priority across the nation with CHIP process. And a lot of the work, this is where I'm going with this very long answer, of those initiatives around mental health, and that includes awareness and resources, falls under the CHIP within a county. But unless you have an action team and a coalition, it could be that you don't have resources or knowledge of resources of what's within your area. And Wisconsin is a very rural community or state. We have a lot of rural areas. We know that, and I'll use farmers, for example. People don't talk about this. Farmers have a high rate of suicide, of mental illness. It can be very isolating. The resources in rural areas are very limited. And then I go back to, what do we need to be doing on a federal level? Well, we should never be taking away virtual therapy and reimbursement for that. If we're allowing psychiatrists within hospital systems to do assessments right there for an individual, we should continue on as a nation to fund virtual therapy. And it's not for everybody. A one-on-one session with somebody face-to-face may be the only way you want to do therapy, but it should be an option in this country, and insurance companies should pay for it.
That aspect of kind of mental health care as a deeply personal kind of avenue that somebody seeks, that comes to the aspect where having just a state affiliate that sees over the population within the entire state may not just work for some people. Right. For people who feel deeply stigmatized or are more apt to get help with a very personal connection, that's something that we just don't have kind of the groundwork for within our state, and something we're very unique in that aspect of being able to serve Sheboygan County and going up into local counties around us. But especially in these rural communities, they just don't have that kind of capacity. Right. So that just speaks to how much further we need to go in producing nonprofits and platforms for people to engage in mental health while this crisis that we're seeing is increasing exponentially. Absolutely. And so you spoke about traumatology and working down in Florida with hurricane survivors and people who have been through national level crises. Is there any similarity to that you're seeing in mental health within communities? Oh, most definitely. I mean, I think it comes in many different ways, from Safer at Home, looking at communities, pockets of communities here that went through their own. It was the beginning, then they were in the middle of the trauma, then they're, the long-term effects that are going to be out there, and we know with COVID and mental health, there are long-term effects that we're not even seeing yet. I look at some of the tragedies that have happened here recently. We had the loss of a teen. Well, we've had the loss of several different teens due to suicide within the last few months. Yes. We had the highest suicide rate here within our county in 2021, that we ever started recording. When that occurs,
it's a community. It's a community impacted. It's school systems, it's churches, it's the neighbors. It's, it is a disaster. It is a trauma that is occurring within a community. And I remember several months ago, we ended up putting something out. Our community is hurting right now. We had a mother who ended up taking her son's life. This whole town was peppered with Purple Hearts to show support. When that happens, we're all moving through this at varying levels of trauma, and one of the things that I put down on our post was, you don't have to know somebody personally to have that grief. We look at, I use the example of Robin Williams. When he passed, you had, the world was grieving his loss. We were collectively traumatized. We were collectively going through grief together. And, it's something that this community in particular, we have had just so much tragedy happen here. And I'm sure no matter where you are listening to this, you could probably say the same for your own communities. But what has shifted has been the conversation of mental health. We're talking about it in schools. We're talking about it in workplaces. We're having community events about it. We have billboards up. It's okay to not be okay. We have to talk about it now, because if we end in what we call here at Mental Health America, stage 4, you're going to be presenting with a crisis, a mental health crisis, or your loved one. So the more we talk about it at a preventative level and normalize it, we are going to, if we sit down a decade from now, where will this change be? Because that silver lining of COVID has allowed us to lift that conversation to a higher platform.
Using Dana's corporate lingo, I wanted to circle back to one thing you touched on, and it's about tragedies within our communities, and especially violent tragedies, and that stigma of mental health that kind of presents itself within these tragedies, and how that kind of perpetuates the stigma of being afraid of people with mental health. I know that's a conversation that we've had before. Could you elaborate on that a little bit?
Right. I mean, it's at the forefront. We have gun violence going on, mass shootings, this conversation, and I've gotten in so many arguments lately with individuals about this. Individuals with mental illness are violent. Oh, so I was a violent person because I had mental illness? Well, no, that's not what I'm saying. But you are saying that. When we categorize mental illness and violence together, we do injustice to the conversation around both of those topics. Are individuals that are violent having some sort of crisis, poor mental health, whatever, mental illness, whatever you want to call it? Yes, but to categorize it all into one category, I think is deflecting against our conversations on violence in general, whether it be guns or other things. So,
I mean, it's kind of like saying that everybody with heart disease has a heart attack.
Right. Well said. Right.
So we're getting kind of, well past the time that we were supposed to be done. But I just wanted to kind of wrap this session up with, do you have any advice for community members, maybe people who want to engage with their community around mental health, individuals that are seeing that lack of support within their communities? Especially, we talked a lot about rural communities, especially within a state of Wisconsin that is so rural. How can community members engage and make sure that they are trying to fill some of those gaps?
Sure. if you're listening to this and you want to get involved and you don't know a local organization in your area, call us. We'll connect you. It's that lived experience. It's that peer drive. Hey, I've been down this path. I want to do something. I want to give back. It's like volunteering at any other level. We love it when individuals come to us and say, you know what? Because all of our support groups here are peer driven.
Mm-hmm.
I want to give back. If you want to give back, but you're not sure how to do it, contact a local mental health agency or call us and we'll connect you with somebody in your area. We need more volunteerism around mental health. And that could be anything from working at the public health department to supporting your local law enforcement. And I'll do a shout out to our law enforcement here. They've all gone through crisis intervention training, to understand the signs and symptoms, to respond to individuals with a mental welfare call or somebody in a crisis. It's important that we're supporting systems as community members also that are meeting the needs of individuals around mental health and behavioral health.
And peer support is becoming a much wider kind of area of support than it was previously. And the idea that somebody who has lived through mental illness or any mental health issue can be there for other people. And there's a lot of stigma around that topic as well that we're seeing, but it's also a wonderful support system that is emerging within our communities. So even somebody who has lived experience with mental illness can be some community support for others, and just engaging with mental illness and talking about your own experience can really be a lifeline for somebody else in the community that is in crisis.
Absolutely. It is recognized now on a federal level how well, there's evidence-based that peers can shift the way that somebody's accessing care. And this conversation just isn't mental health. It's somebody who just had a heart attack is now connected with somebody who has survived and walked that path of having a heart attack and taking their meds and walking and eating well and whatever it looks like. Peers are driving wellness in this country, and the federal government is recognizing it and backing it with money, which hip hip hooray to that.
Mm-hmm. This is a conversation that I thought about just a little bit earlier, and how within the mental health, mental illness framework, we're specifically focused on remedying mental illness. And it's not preventative in most clinics. We don't prevent mental illness as a nation. And something that we do is the education component and the social and emotional learning. I was wondering if you wanted to talk a little more about how preventing mental illness and at least educating people on what mental illness looks like can lead to alleviating this crisis that we're in.
Right. I mean, prevention for poor mental health. And I always use that word. I don't know if you've noticed that, poor mental health, because, when we have this conversation about, well, you have mental health or, you have mental health issues or whatever it is, I have poor physical health. I have poor mental health. It's not doing well right now, whatever that looks like versus mental illness. But prevention looks like childcare. Prevention looks like food on the table. Prevention looks like somebody who has a roof over their head, a job. This is all prevention. Safe neighborhoods. A doctor, a dentist. All of these things are preventative measures for us to have good mental health. Now, if you have all of those, does that mean you're going to have great mental health? Absolutely not. We also have, genetics. We also have trauma that has occurred. Life experiences. Where prevention comes in is access to care at that point. And I'll use, an example. Somebody just lost their son. What supports does this community have for this family? Is there a support group out there that they can go to hear individuals that have walked this path? Is there somebody that can be there right away as a therapist to address their needs from a trauma lens? Because this person has now been traumatized because they've just lost, a child, let's say. It's community support. It's workplaces understanding that a person needs accommodations now because they are experiencing something around their mental health that's preventing them. All of these measures are preventative measures from somebody escalating into an illness or a crisis.
You talk about the parity between physical health and mental health. And one thing that I think about is we go to our family doctor for a yearly checkup or bi-yearly checkup to make sure that our physical health is at a point where we don't need routine care. And I just think about that in contrast to what we do with mental health. And even right there, just thinking about it, it's really that remedy. Once something gets bad, that's when we step in and start engaging with our mental health, at least from a clinician and care point of view. And it always reminds me of the idea, I think that it was Benjamin Franklin that said that the future of medical care is preventative. And I just wanted to relate this to the education and the MCI programs, the Mindfulness Classroom Initiative, where we go in and we talk to children about different aspects of their mental health and talking about what are feelings, because you'd be surprised at how many adults don't know how to label their feelings. And if you can't label your feelings, how are you supposed to engage with your emotions and your feelings in a healthy way?
Right.
And so I think a lot of the shift that we need to do in the mental health field is shifting to that preventative, because right now we're trying to pick up all the pieces as they shatter and trying to put back like a mirror that's shattered while it's still shattering. And if we can prevent it from shattering, that's going to alleviate a lot of this crisis.
Well, it's interesting you should say that. And I'm glad I actually get to say this next thing, because it just makes me mad. So, just recently over the last few years, the hospital systems are now asking, so I need to ask you this question. Have you thought about self-harm in the last, X number of days or a year or whatever the questions are? And every time, Keegan, I go in for my physical appointment of whatever's going on with me, now I have to do this. This is how it's presented. I have to do this. I have to ask you these questions. You're not thinking about harming yourself, are you? Or, I'm sorry, I have to ask you this. Have you hurt yourself So how am I going to answer these questions? I'm not going to be open. Mm-hmm. It's a lot of education also on behalf of the medical field to say, this is one, this is holistic. Your mind and body are one. They're working together. And to put the stigma around the question, because you have to ask it or you're uncomfortable about asking it, you're doing a disservice to your patient who's coming in. And we know and I don't have the data with me right now, but those individuals that are going to self-harm or have a plan or do something, see their general practitioner within 30 days of making an attempt. And these are important data sets that we need to be having conversations with our medical systems around it. And it shouldn't just be one class in medical school. It should be ingrained in everything that they do, because you can't just have physical health. You have to have both. And more importantly, you have to have good mental health.
Well, thank you so much for this, this
you.
conversation. There's a lot that was all packed in this. Just lastly, how can listeners get engaged with our nonprofit here and the work that you do? How can people follow your work?
Yes, follow us on all of our social media channels. Spread the word. Support us in any way that you can. And that does not mean financial. I mean, support us about having the conversation about Mental Health America, about NAMI, about mental health organizations within your community. We are all working together to lift this conversation, but we need you by our side. We need you as mental health champions.
Thank you so much, Julie.
Thank you, Keegan.
I hope everybody found this conversation as interesting as I did. Stay tuned and think on this. Thank you for listening to the Think on This podcast with MHA Lakeshore. If you enjoyed this podcast, subscribe to our feed to be notified about the latest episodes. If you are interested in MHA Lakeshore and want to follow our work, you can find us on Facebook, Instagram, and our webpage, all of which are linked in our bio. Additionally, you will find a link to a form where you can leave any feedback or suggestions for us. We would love to hear what you have to say, so please reach out. Lastly, if you found that this content was of value to you, you can donate to us on our webpage by clicking on the yellow donate button in the upper right-hand corner. As a nonprofit, we rely primarily on grants and donations to operate, and every donation allows us to have a greater impact. By donating, you are supporting our vision of mentally healthy communities where all individuals thrive.